Hi, my name is Ashlyn Smith, and I'm a board-certified PA specializing in endocrinology. I'm the founder and lead clinician at Elm Endocrinology and Lifestyle Medicine in Arizona. Today, I'm excited to talk with you about type 1 diabetes myths, staging, screening, and treatment in this 4-part video series. Over the course of my career, I've heard many misconceptions and myths about type 1 diabetes, and honestly, I think we've all believed a myth or two at some point. But today we are going to tackle them head on. The first myth we will discuss is that type 1 diabetes is almost always diagnosed in children. Actually, it's estimated that up to 62% of T1D cases develop in patients older than 20 years, with 37% of cases developing in those over 30 years. So while the timing of diagnosis may peak between ages 10 and 15, we see that cumulatively, those diagnosed in adulthood are more the norm than the outliers. When adult patients, especially those experiencing obesity, come in with concerns and lab work suggesting diabetes, they can be misdiagnosed as having type 2. In fact, 40% of adults over 30 years old with T1D are initially diagnosed with T2D. It's so important to characterize diabetes correctly, as early and appropriate intervention is essential for both type 1 and type 2. I want to take this opportunity to also bring up LADA, or latent autoimmune diabetes of adults. It is autoimmune diabetes diagnosed over the age of 30 and progresses more slowly than traditional type 1 diabetes, making it easy to misdiagnose as type 2. In clinical practice, LADA and type 1 diabetes are essentially treated the same way, with insulin therapy long-term. So while age may give us some clues about the type of diabetes an individual has, we need to use additional data to screen and diagnose. We will discuss that more in another video, but for now, let's highlight another myth related to diagnosis. Our second myth is that C-peptide can be used for definitive diagnosis. However, C-peptide is non-specific in diagnosing diabetes type. Let's talk a little bit about why. As a reminder, type 1 diabetes is a chronic autoimmune disease in which insulin-producing beta cells in the pancreas are destroyed in an immune-mediated way. These patients eventually secrete little to no insulin, impacting their body's ability to use glucose. In contrast, type 2 diabetes is a metabolic disease. These patients can still produce insulin for some time, but the body has become resistant to insulin, increasing blood glucose. This causes the pancreas to make more and more insulin until beta cell failure occurs. So how does this relate to C-peptide? C-peptide is a byproduct that the pancreas makes when producing insulin. So we may be tempted to think it will always be low in T1D and always be high or normal in T2D. However, since adults diagnosed with type 1 diabetes usually have a slower progression to insulin dependence, they may have a detectable C-peptide initially. In T2D, the pancreas is still producing insulin, and the C-peptide may be normal or high at first, but once the beta cells begin to fail, C-peptide levels eventually become low in type 2 diabetes as well. So how do we differentiate between the two? That's where autoantibodies come in. More on this in our next video. Myth number 3 is that type 1 diabetes is genetic, and therefore patients are likely to have family history. It is true that there is a genetic element to type 1 diabetes. Those with a first-degree relative with type 1 diabetes are 15 times more likely to develop type 1 diabetes than those who don't. But that doesn't mean a family history is necessary for someone to develop type 1 diabetes. In fact, up to 90% of cases occur in those with no family history. And with that, we've covered several of the myths that I hear from both clinicians and patients. In our next video, we will dive into the how and why of staging of type 1 diabetes. See you there.